An emergency is developing in the labor and delivery department.
This is a 34-week premature baby who's being delivered by cesarean section. Okay, let's go. She's in there. Let's go. So we're taking our full transport team down to this delivery.
A new mom is having severe complications and her baby needs emergency care.
The mommy has an abnormality of the placenta, and she has a placenta percreta. So that makes it a very high-risk delivery.
Dr. Stephen Elliott and his team from the Neonatal Intensive Care Unit are always on call.
It's natural to feel anxiety because we never quite know what we're going to get at a delivery.
The team has all the equipment they'll need to keep this baby girl alive.
So taking our transport rig, it has the incubator for to keep the baby warm. It has ventilation and monitor equipment on it, and it's also equipped with intravenous pumps.
They're already on their way to the delivery room.
We expect everything to go smoothly, but we're ready for everything. Hopefully the potential hemorrhage is a maternal issue and not a baby issue, but it's always a possibility that the baby may lose a lot of blood if there's a lot of hemorrhage from the placenta. So what we're thinking about before we go into the delivery room is we're thinking about that baby might need volume, it might need a blood transfusion, and it might need cardiovascular support.
Dr. Elliott quickly collects the newborn.
Let's go. No, let's go. I'm not going to save any time by someone being there 10 seconds earlier.
The premature newborn is alive, but struggling.
She needed respiratory support. We needed to put a tube into her lungs and support her breathing.
During the pregnancy, leaking amniotic fluid damaged the baby's lungs, leaving them underdeveloped.
Erica, we have Robin setting up the ventilator.
Yes, we do.
Okay. We then brought her back to the Neonatal Intensive Care Unit. So we anticipated a baby who was going to be quite well and not need very much support.
But that wasn't the case. The team will spend the next several hours helping the baby breathe. This newborn girl was born with underdeveloped lungs and is fighting for her every breath.
When she was born, she had considerable difficulty and trouble with her breathing.
The newborn needs several life-saving medications.
I need 30 mLs of normal saline. I need a single lumen and a double lumen, 3.5 French. We'll take 4 mLs of D10. B, I need 0.4 milligrams of morphine. I need 0.4 milligrams of Pavulon.
For a baby just hours old, the dosage must be precise.
The normal saline, I've got 3 of these. We can use these.
I need 5 mLs of surfactant, please. I need a stat chest x-ray, please.
Here's D10 right here. Okay, D10 right here.
4 mLs. Marcus, I could take some cloth drapes here as well.
With decades of experience, Dr. Elliott knows exactly what the infant needs.
I need a single lumen catheter, please, as well.
Yes, just getting it.
Can we get a dopamine infusion set up?
100 mics per ml?
Probably a high concentration.
We do 3,200 mics per ml?
Yeah.
Okay, do you want heparin in that too?
Yes.
Okay,
we'll
get that.
put it through the UVC.
Okay.
Dr. Elliott must now perform an extremely delicate procedure. The baby's umbilical cord will serve as a lifeline, allowing medications to trickle into her tiny body.
And the UVC right now is at 11. I'm going to go ahead and secure it.
Morphine.
Yes. Can I take a double lumen, size 5, please? I'll take another blood gas syringe. I'll take a blood sugar and a blood gas from here, please.
The baby is finally stable, and Dr. Elliott now has a moment to check in with the baby's father.
I met you in the waiting room just before the C-section. We do take time out as much as we can to educate and inform the families exactly what's going on. We encourage the families to come in and be with their babies, even during these critical times. After all, it's their baby, and it's their flesh and blood. It's their family, and we feel that they have a right to be there. It's very overwhelming for families. Families expect a normal newborn. I think the biggest problem that she's got is that, you know how mommy had a very small amount of fluid in the sac. That affects the lung development, and so the lungs are very underdeveloped because there was a very small amount of fluid. We try and reassure them, and yet at the same time give them enough information to help them understand what's going on. When babies are admitted to the neonatal intensive care unit, it's quite a harsh environment. It's quite shocking for families to walk in and see their babies surrounded by IV lines, by cardiac monitors, electrodes. There's a lot of beeping, there's a lot of activity, a controlled level of chaos as multiple people are performing their functions in the resuscitation. We were anticipating the worst, hoping for the best, but we were down in the trauma OR and this baby clearly has hypoplastic lungs. So we've intubated, we've given surfactant, and I've just placed lines. We've got our blood gases pending, and she has received morphine and Pavilon. So she's sedated and she's paralyzed.
The team has done an amazing job. The newborn girl has been stabilized.
At this point, this baby is reasonably stable. She does still need a lot of support on the ventilator.
She will now be transferred to a regional facility that specializes in the long-term care she'll need.
It's not going to be a quick fix to this problem. Her blood work numbers that tell us how her lungs are functioning tell us that her lungs are very sick. She's going to need additional help. We're going to have to transfer her. I'm working on where exactly would be the best place for her to be transferred to, because she's going to need a lot more support in the next couple of days. She needs a lot of cardiovascular support. I anticipate that eventually she will do well, but she's going to need critical and intensive care for the next several days.